Good evening, and thank you for joining us for this special show on cancer care powered by Janssen Oncology, the pharmaceutical arm of Johnson & Johnson. I'm your host, Anisha Nayar Dhawan. In this special series on cancer care, we will be turning the spotlight on the rising incidence of cancer in our country. We'll try to understand the various aspects and nuances of different kinds of cancer and speak to experts to know if people can actually reduce their risk of cancer. On our show today, we will be talking about multiple myeloma, the symptoms, causes, and risk. Now, multiple myeloma is a kind of a blood cancer that forms in the plasma cell. The plasma cell is a type of a white blood cell. Now, healthy plasma cells help you fight infections by making antibodies that recognize and attack germs. But when you get multiple myeloma, cancerous plasma cells accumulate in the bone marrow. Cancer is known to be an uncontrolled growth of cells, and that's what happens. Your plasma cells grow uncontrollably in the bone marrow, and they crowd out the healthy red blood cells. Rather than produce helpful antibodies, the cancer cells produce abnormal proteins that can cause a lot of complications in your body, one of which is, of course, the bones becoming weaker. Now, could a persistent backache be a sign of multiple myeloma? Do you feel fatigued or easily tired? And does this happen frequently? Could you be suffering from anemia, which is also perhaps brought about by this cancer? Do you frequently fall ill? Is this a sign of weak immune system, or could this be multiple myeloma? In our show today, we will discuss the symptoms, diagnosis, and treatment of multiple myeloma. Please welcome our esteemed experts who are joining us today to discuss this on the show. Please welcome Dr. Rahul Bhargava, Director and Head Hematology, Hemato-Oncology and Bone Marrow Transplant, Fortis Memorial Research Institute of Blood Disorder, Gurugram. Please welcome Dr. Sameer Tulpale, Consultant, General Hematology, Hemato-Oncology and Bone Marrow Transplantation, Kokilaben Dhirubhai Ambani Hospital, Mumbai. We'll also be joined very shortly by two more experts, Dr. Chandrakanth, MV, Consultant Medical Oncology and Hemato-Oncology, Narayana Superspeciality Hospital, Kolkata, and Dr. Pawan Kumar Singh, Head Hemato-Oncology and Bone Marrow Transplant, Hemato-Oncology, Artemis Hospital, Gurugram. A warm welcome to you, gentlemen. Thank you so much for joining us on this show today. Multiple myeloma is a blood cancer. Now, Dr. Sameer, till about a few years ago, the diagnosis of blood cancer used to be very scary. People were like, blood cancer, it's all over your body. You have very few chances of survival. How do you view multiple myeloma? And if somebody is diagnosed with multiple myeloma, what would you say to them?
Right. So thank you, Anisha. Thank you for the wonderful introduction, and you've set the ground quite well and have described myeloma quite well as well in your introduction. So I think you're right. I think until a couple of years ago, especially when it comes to myeloma, we didn't have that many therapeutic options. So I think telling the patient that you've got blood cancer, the dreaded C word of cancer itself, patients used to lose hope. And the outcomes of myeloma before the advent of newer agents wasn't all that great. But recently, when I say recently, we're talking of the last sort of 10, 12, 15 years, that we've got newer drugs which have been coming through the pipeline, each one better than the previous one. And in combinations, the myeloma can be controlled fairly quite well with good quality of life for the patients. So I think what I would say is that, early diagnosis is the key. So if they've got symptoms or there's suspicion of a myeloma or a cancer, they must get themselves investigated quicker, because the newer drugs that we have currently available can control the disease very, very well with a good quality of life. I must add, though, that myeloma still remains incurable. There's no cure as such, but it can be controlled very, very well. So you may find patients who are on medications for probably a protracted course, but it does help to control the myeloma and give patients a good quality of life.
All right. Dr. Bhargava, let me come to you. Now, there are different types of blood cancers. There are many types of blood cancers, and myeloma is one of them. So how similar or different is it from other kinds of blood cancers?
Thanks for having me on the show, Anisha. Let me first dispel the whole thing that blood cancer is no longer a death sentence.
Mm-hmm.
And every year, we are conquering more and more. Every year, many more people are surviving and defeating blood cancer as we speak.
So,
Multiple
Dr.
myeloma
Bhargav,
is slightly different.
Dr. Bhargav, you want to dispel the myth that blood cancer is the death sentence, right?
Yes,
Okay.
Absolutely, Anisha. The blood.
Please go ahead.
So, in blood cancers, more and more people are surviving by virtue of revolutionary medicines which are coming up. When it comes to specifically to multiple myeloma, I would not like to categorize into a cancer, but I would like to keep it separately because it is a long protracted course of multiple myeloma. It can present differently. It can present with bony pains. It can present with spinal fractures. It can present with renal dysfunction. So that's a different presentation altogether, which is not like weight loss, fever, and swelling here and there, but more of bony diseases or kidneys and so on and so forth. And a disease mostly occurring in a fifth and a sixth decade, where there could be low hemoglobin and so on and so forth. So first is the presentation, which is different for multiple myeloma. Second is a long-term medications which are not particularly leading to nausea, vomiting, hair loss, and you seems to have a beautiful hair. So people don't lose hair these days, and they can maintain as beautiful hairs as yours are throughout their chemotherapy course without ever people knowing that you are suffering from a blood cancer called multiple myeloma. So it means the medicines have become more targetable. And when I said more targetable, it's a 2-second IV push. It's a 2-second injectable on a skin, under the skin like insulin. Can we ever thought over that? Can we ever thought that these are the things like oral medication is going to help us in living longer? Probably Dr. Samir said it right, that we might not be able to cure, but what people in 2010 was surviving with 2 to 3 years, now are surviving close to 7 to 8 years, which means if you develop myeloma today in 2022, you might be able to live in 2029, where you might have a cure at that moment of time. So we are living longer.
Okay.
So the ability of a drug, a simple drug, oral drug, without the telltale signs of the chemotherapeutic drugs which has been imbibed into our mind because of the Hollywood and the Bollywood of what we see, are not there in myeloma. So myeloma is a different ball game where we need to understand and not not fearful of the fact that we are going to die or we are going to have side effects of the chemotherapy. So myeloma stands tall into a different category. Is a cancer, but highly controllable cancer with a good quality of life, so much so that you can go and do your work on a day-to-day basis.
Okay. Dr. Chandrakanth, Dr. Rahul Bhargav has described to us how different myeloma is. There's no cure, but your quality of life is nearly as good as possible because of good medicines. What similarities or differences do you see in your patients who have myeloma versus those who have other types of blood cancer?
Thanks, Anisha, for having me, and I would say good evening to everyone and for the opportunity for me being here. So, well, I think both Dr. Samir and Dr. Rahul have excellently commented how myeloma is different from the existing cancers. So, we are basically, the moment we say about blood cancer, we always assume that it is a leukemia. So, it's a cancer of WBC. So, this is what we usually think. Well, if you look into the WBCs take their birth and then they have their children and then they keep maturing on. So if the cancer happens to the parent, in the sense the most premature cell, then we call it as a leukemia, where the proliferation rate is so high, like the doubling time is very short. So that is a leukemia where we see low platelets, very high WBCs crossing blacks. So, and the typical movie where the first day the patient faints, second day a black spot appears, and the third day there is bleeding, and the fourth day the patient dies. So this is what a blood cancer we usually think of. So this is in the early premature cell multiplication, high proliferation rate, leukemia. So myeloma, as you very correctly said in the introduction, it's the cancer of plasma cells. So plasma cell is like it's a father, like it's a matured cell which doesn't proliferate. It's a lazy cell that doesn't multiply so fast. So the proliferation rate of a plasma cell is not that like a young immature cell. So that's the reason why a myeloma patient doesn't come to you with the typical filmy picture of bleeding and all those symptoms. So the moment you have a myeloma in mind, we must imagine a picture, an elderly 60s gentleman or even a lady who has constant back pain, low hemoglobin, was walking, feeling weak, requiring blood transfusion, and has become bedridden over a period of 4 months. So this is the history we usually look into. Any elderly person who comes to you with repeated anemia, weakness, multiple bone pains, usually they start visiting orthopedicians, they start visiting neurologists, they start taking physiotherapy, all alternative medicines, multiple painkillers doesn't go. And then someone finds out there is low hemoglobin and someone sends a M band in the blood and they figure out it's a myeloma. So this is a typical picture of a patient who comes, gets referred across the specialties, either from an orthopedician or from a general physician, with low back pain, and the patient is typically bedridden. So whenever a patient of this sort comes into my clinic with this picture, with a low hemoglobin and multiple bone lesions in the bedridden patient, so the patient would have already got a feel that I have got cancer, and that too a blood cancer probably. So the first thing I would assure the patient is, you wish and you pray that you have a myeloma, because this is one of the best manageable. I understand there is no cure. I mean, there is no cure for diabetes and there is no cure for hypertension too. So we have to manage them with medications. So as Dr. Rahul was excellently saying, it's like just like insulin. So for diabetes, you have to take daily injections. For myeloma, it's a weekly injections. So it is easier and more practical to treat a myeloma than any chronic disease like diabetes or hypertension.
All
So
right.
yeah, so
Right.
this is the typical presentation we see in our clinic, and I would always say a patient is on a stretcher. I say pray that it is a myeloma, which we confirm with the marrow, and then I would counsel them that by 1 month you would sit, and by the second month you will start walking, and the third month you can go to the market and get things. So it's a very optimistic feeling as an oncologist when compared to other cancers. Yeah.
All right. Dr. Pawan, Dr. Chandrakanth has explained to us that the plasma cell is a matured cell. It's not like the baby cell which are affected in a leukemia. And as a result, it may not be expanding vociferously. But these mature cells also have a role to play. They do fight infections. And because of them getting affected by cancer, they're all over the place and they're producing proteins that are hurting the body. How does myeloma affect people? The symptoms Dr. Chandrakanth has mentioned is weakness, backache. How do people know that something is wrong and I could be having this kind of blood cancer?
Yeah, hello. Hello, everyone. And thank you, Anisha, for this meeting. So, yeah, infection is an important part. Means it could be important. In fact, if we see in myeloma, it is the most common cause of death. And usually the infection develops if the disease is not under control. So treatment is very important. See, these myeloma patients, first thing is that they should not ignore their symptoms. And once they have the diagnosis of myeloma, they should get the treatment as early as possible. Treatment is pretty simple, which Dr. Rahul and Dr. Venkatesh, they have already mentioned. Not like other standard oncology treatment where we get all the symptoms of nausea, vomiting, pain, hair loss, all these kind of.
So those are the side effects of the treatment. Could you tell us what are the specific symptoms? Because backache, most women will have a backache, even in 40, 50s, they have so much stress of packing the kids, tiffin, doing the work. Most women go to sleep with a backache. Nobody thinks it's a cancer. Then anemia is rampant in our country. what is that one thing that should tell you, oh no, something is wrong. This is not the regular run-of-the-mill problem that you have. This needs to be investigated.
See, the most common symptom of myeloma is the anemia. Anemia related the most common symptom, and they can have symptom related to anemia. And the other thing, the next common symptom is the bone pain. Sometimes very means rarely the patients are diagnosed when they consult a nephrology for kidney dysfunction. It can be decreased urine output, or during routine evaluation they found that creatinine is high. And usually myeloma, see, we have to evaluate these things. The nephrologist, the orthopedic surgeon, they have to see, they have to anticipate that it could be myeloma, because for these symptoms, obviously the patients are not going to be seeing a hematologist or an oncologist, because myeloma, the presentation, if they have the bone pain, they will be consulting orthopedic surgeon. If they have routine like symptoms related to weakness and all these things, for that they will be consulting a physician. So if they have persistently these symptoms, anemia not correcting with routine hematinics or supplements, then there, especially in elderly people, they have the physician and the other doctors, they should get the evaluation done. See, simple thing is that in most of the time myeloma, you see the AG reversal is there. So if in their liver function test, if they find that this abnormality is there, very high globulin levels, this also should give a possibility, should give a suspicion of myeloma, and it should be evaluated. If they have mild kidney dysfunction, creatinine is going up, so then the possibility of myeloma. Anemia with bone pain, elderly people, myeloma should always be suspected.
All right. Dr. Bhargav, say there's a suspicion, then how is it diagnosed? How is myeloma diagnosed? And is there a staging here of what stage myeloma is in when the patient presents himself to the doctor?
Yeah. So once as Dr. Pawan has said, the suspicion remains the key. And any symptoms which comes to the mind, we need to think about blood cancers as we grow older, so as to rule out it early, because it becomes very important that we rule out things pretty early in the disease status. Once that is being done, and you go to a physician, and many more audiences are into general physician or in the general public. So simple tests like CBC, ESR. ESR is high, disproportionately high to the hemoglobin, which is low. Hemoglobin of 10 and say ESR of 90. Remember the word called ESR. Second thing, liver function test where albumin and globulin are reversed. For a common public, just keep on noting it, because albumin and globulin are there in liver function test. So these are the commonest tests. These are the garden variety of tests which you do on a day-to-day basis. So look at the albumin and globulin, and it will be reversed. It means the globulin will be more than the albumin. Otherwise, normal is albumin is more than A is more than G. When G becomes more than A, think about myeloma. Third test, calcium, serum calcium. We keep on eating calcium tablets without ever knowing that if your calcium is high, that could be the signs of multiple myeloma. So these are the three simple blood tests which we need to do. After that, simple blood test called bone marrow test, where the machinery of the factory remains for producing the plasma cells. So if it is something is wrong, you have to visit the factory, which is in your long post. It's a 15 to 20 minutes job. You go to the OPD in a daycare. It is being done under local anesthesia. You might feel pain. Pain is again a very relative symptomatology according to the people. But let's not be afraid of bone marrow test. Even if you're afraid, there are ways of doing it, but that needs to be done. So what we need to do, as Raghuram Rajan once said, I do what I do. And that's what we need to do, and we need to do a bone marrow test. There's no simpler methodology. After that, there's a imaging, either people where there's an economic crunch, where we can have financial crunch, we can do x-rays. But if the financial crunch is not there, or the PET scan needs to be done to look for the lytic lesion, which is a moth-eaten appearance, or somebody has eaten up the bones, which is like lucencies you can see in the bone, which is dark shadows and the light shadows in the bone. You can see that somebody has eaten up your bone by virtue the plasma cells have eaten and they have made the holes there. So these are the simpler tests, and the more complex tests to know how good, bad, ugly I look. Anisha looks so beautiful and I look so ugly. Why? The reason is in the genetics. Similarly, Anisha has said about the staging. Yes, we do have staging 1, 2, 3 because the country is obsessed with staging. We do have staging, but beyond, every hematologist and oncologist will look beyond staging, which is the genetics, which makes Anisha so beautiful and us less beautiful, which is genetics. Remember, and people who eat fish or even who don't eat fish, and every kid would have listened to this story, fish jal ki rani hai, machli jal ki rani hai. Fish is the test which helps you in determining your genetic status, because genetics means good, bad or ugly disease. It does not mean that it is going to get transmitted to your kids. It only means a fish test means it will classify you into a good risk marker or a bad marker, because it will help in deciding 3 factors. One, what medicine needs to be given, whether the expensive medicine needs to be given or not. Second, whether bone marrow transplant needs to be done early or late, because I feel irrespective of cytogenetics, every multiple myeloma needs a bone marrow transplant. So the rest of my speakers will explain to you that. And third, what is the prognosis? Because you want to know how long you are going to live. Everybody want to become an astrologer, and we are like doctors are the biggest astrologer. And a day we predict who's going to live how much, and that's based on the data itself, which might be right or wrong. You might defy your odds of living or dying, but still that data helps you in knowing how long you're going to do. That's called prognosis. So that is why you require these specific sophisticated tests called FISH and serum protein electrophoresis, which shows you a church-like spike, which is M-band. So these are, in a nutshell, you spend 20, 25, 30,000 rupees for making a diagnosis, which is complete, which tells you the name of the disease, type of the disease, cytogenetic wise, and stage of the disease.
All right. Very comprehensive explanation. But the thing, first off, which is important is that simple blood tests can give you a first clue. So please see your blood test and keep those parameters in mind, the ESR, the hemoglobin, the albumin, and the globulin, so that you also are a little informed of what your blood tests mean. Dr. Sumesh, the FISH tests or your genetics, Dr. Bhargava says, will not determine whether the disease is passed on in the family, but also your genes determine how the cancer performs in your body and what would be the best drugs to give you. So our panelist has said, like Dr. Chandrakanth also said, that the first month the person on the stretcher, the second month he starts sitting, the third month he starts walking and leads a normal life. You've also said he leads a normal life. In your practice, how many patients do you see who come who are already sitting but have myeloma, or do you all see most patients who are really badly off, not able to get up? And this genetic testing, the FISH test, is it a standard done for all patients? Could you tell us more about that?
Sure. Thanks, Anisha. I think Rahul and Dr. Chandrakanth have actually, as well as Dr. Pawan, have explained myeloma quite well. So we know so far that it's not curable but can be controlled very well. That we have to do simple blood tests, as Rahul said, starting with your blood count, your ESR, looking at the liver function, looking at the M-band spike, the kidney function, the creatinine, that's important as well, the bone marrow test, and then the imaging to look at the bones to see whether there is bits eaten away, whether there are collapses, fractures, and so on. Now, typically, what I tell my patients a lot of times, especially who have got a lot of bony disease, it's like a storm. When a storm hits a village, it leads the destruction and the storm goes away, but the destruction is still there, and it takes time to rebuild the village again. That's something similar with bony disease as well. What happens is, you get the myeloma patients who have got a lot of bony disease. There's a lot of lytic lesions, fractures. You do tend to control the myeloma fairly well, but then it's, the repercussions of the fractures, which takes time to heal and the pain to go away. So it is those sort of chronic things which take time. Now, in terms of, the spectrum of the patients that we typically see in our outpatients and the inpatients, it's quite a spectrum. We have typically patients who would come walking to us in the outpatient department. And mind you, most of these are referrals. So probably the general physician has actually looked at, investigating anemia thoroughly and hasn't actually found anything when they come to us to investigate something more when we find a myeloma, or an orthopedic surgeon where the patient goes to them where there's a collapse of the spine of the vertebrae, they don't find any obvious reasons or suspect myeloma, they come to us, or the kidney doctors where there's renal edema and renal dysfunction, and there's not exactly a definite cause when we find a myeloma. So to answer your question, it really depends on which organ has been impaired a lot. So if the bones are impaired a lot of fractures, which makes them immobile, then for them to get better takes slightly longer, because as I explained, the bones take longer to heal. On the other hand, if it's just anemia that what they come with, then managing them with probably even maybe a blood transfusion initially, giving them some supplements or injections to boost their hemoglobin, some supplements, including the anti-myeloma treatment, does tend to get them up fairly fast, up and about. So I would say that depending upon the spectrum of the disease, typically I would see about a third of the patients who would be quite incapacitated. But majority, 2/3, are not that incapacitated and can be managed fairly well with medications and supportive care.
All right. Dr. Chandrakanth, can you explain the staging to us in a simple fashion so that the patient understands what stage is in? Now, the more I hear all of you, the more I feel that this is a blood cancer, but it's affecting the bones. The bones are hurting. So, for the patient to understand what stage he is in, stage 1, stage 2, stage 3, what would be the symptoms?
Well, the word staging is quite popular in a solid cancer. For example, when a patient has a breast cancer, we always want to know, is it confined to the breast or it has spread elsewhere, like whether it has gone to lungs or liver and bones and so on. So whereas if you come to multiple myeloma, it's a blood cancer. So here the staging, the word is sort of not actually staging. So like blood actually flows in each and every part of the body. So here staging doesn't mean we are looking into the extent of spread, because it is blood, it is spread, of course.
All over.
So the word staging is sort of not that greatly important as far as myeloma is concerned. People keep asking me, what is the stage of my? I say staging is not important in blood cancer, especially in myeloma and leukemia. What is important is, of course, we do have staging depending on something called beta-2 microglobulin and albumin. These are the two markers that we do. It just says how rapid the disease is multiplying and how much is the disease burden. So what is the amount, the burden of disease in the body, and how much it has affected the end organs? As Dr. Samir was saying, it's a minor hit or it's a big hit. It's as big. We have what is called as the CRAP criteria, CRAP. So C for calcium, R for renal, A for anemia, and B for bone pains. And we also have something called O for others, but CRAP looks very attractive for me to remember. So calcium high, renal is kidney, A for anemia, and B for bone. So these four are very important. This is more important than the staging. We call it as ISS staging based on beta-2 microglobulin albumin. So before I venture on to the myeloma aspect,
Dr. Chandrakanth, I'll interrupt. Rahul this side. It also looked fascinating to eat a crab. So crab, myeloma, and crab on your dinner table.
Yeah, sir, I agree. That's correct, sir. So, but it's very easy to remember, and it's very important. Even for us, we put on paper this crab even today. We always write.
For patients or the audience watching me, they could remember these things, so that if they have these symptoms, then they feel like, okay,
yes,
let me get this investigated.
Correct. So
go on.
Yeah. So crab is what I think everybody has to remember, and there are few more things I will just add on. Of course, myeloma is very good treatable. So myeloma comes under a big group called plasma cell dyscrasia. So there are something called MGUS, and then something called smoldering myeloma, and then comes an actual multiple myeloma. So the plasma cells, as we become older, or for whatever reasons, there is little bit of tendency towards becoming cancerous in a very pre-malignant stage. That is what is called as a undetermined significance. Like a person can have a very minimal burden of plasma cells, for example, 3 to 4%, but this may not turn to be a myeloma at all in his life. So these patients, what they need is just monitoring. So many times patients come when an orthopedician keeps finding out why there is a lot of bone pains. He will find a small M band of something like 300 milligrams, and then ESR is somewhat raised, and then we do a bone marrow, and it's something like 3% plasma cells. So here, a minimum plasma cell, a bit rise in M band does not qualify for a myeloma. It may be a plasma cell dyscrasia like MGUS, and this patient may not require treatment for myeloma at all. So for example, we would have heard, I have little sugar. My sugar is around 110. We say you don't need treatment. You just need observation and monitoring. Just like that. Just like that. I just have 3% plasma cell. What all you need is the present bone pains are not because of myeloma. It's because of something else. So we need to be very conscious on these very small aspects of that plasma cell dyscrasia is not a myeloma, but you need monitoring because these patients have a higher risk of getting transformed to myeloma. This is one. As far as the spectrum of plasma
disorders,
yes, spectrum of it's a not that all MGUAS will become myeloma, but they're at a little higher risk than others. This is what we need to know. And the CRAB we understood, and staging is important just to understand the prognosis, but it's not that greatly important. As Dr. Rahul said, risk stratification is very important. Risk stratification is cytogenetics, fish test, as Sir was talking. That is more important because this will help me in deciding what treatment I have to do and whether I should do an early transplant or whether I must stress on the transplant aspect or not. So, number one, remember the spectrum. Number two, remember CRAB. Number three, you remember that staging is, of course, but not that greatly. And number four, risk stratification. So these things become important in myeloma. Thank you.
All right. Dr. Pawan, we've covered a lot of ground in understanding what is myeloma. Now, Dr. Rahul told us that it's the treatment is this injection that you take. And even though multiple myeloma is not curable, it is a chronic disease which can be managed well to the extent that the patient's quality of life is fairly good. So could you tell us what is the treatment and what is the frequency of the treatment and what is the quality of life of the patients?
Yeah, so in myeloma, if we see about there are different regimens.
Dr. Pawan, I'd request you to please turn your video on. We can't see you.
Yeah. So basically, it's a regimen which is being utilized and they are being changed also. So as per the recent guidelines, if you see, the recent guidelines says it should be a triple drug combination, and out of those triple drugs, so basically one drug is bortezomib and other drug is dexamethasone, which is usually the fixed, and the third drug in this triple drug regime is one is either cyclophosphamide or lenalidomide. Lenalidomide has better outcome as compared to So it's a triple drug combination: bortezomib, dexamethasone, and a third drug is lenalidomide or cyclophosphamide. And usually, lenalidomide is preferred, but sometimes because of some reasons like renal, if the patients have already renal dysfunction is there, then usually lenalidomide is not preferred. So in those cases, cyclophosphamide is given as a third drug. And usually, this regimen is given for a period of 3 to 4 cycles. First, the patient is assessed whether he or she is eligible for transplant or not. If they are eligible for transplant after 3 to 4 cycles, if the disease is well controlled, then they should be taken up for autologous bone marrow transplant. And after that, then they should be put on maintenance. For preferable is to give it till progression, till the disease comes back again. The maintenance therapy should be given, and maintenance therapy usually it is the lenalidomide, which is an oral drug. So this is the broad overview of myeloma treatment.
Dr. Pawan, what is autologous bone marrow transplant?
Yeah, so autologous bone marrow transplant, it's an important part of myeloma treatment, and every myeloma should be undergoing bone marrow transplant. So basically, this is high dose chemotherapy. So what is the procedure in this? What we want to give is, we want to give patient a high dose chemotherapy, and this is such a high dose that with this chemotherapy his normal blood counts will not recover. So what do? We first collect the stem cells, keep it outside patient's body, and patient is given high dose chemotherapy. Then these cells are again given back to the patient to restore the hematopoiesis. So in ideal term, I will give you the name of this treatment, because the procedure is like bone marrow transplant. That is why it is called as autologous bone marrow transplant. But actually it is high dose chemotherapy followed by stem cell rescue. So this name itself tells the principle of this treatment, and what we are going to achieve by this is already explained in the name: high dose chemotherapy followed by stem cell rescue. But the procedure is like bone marrow transplant. That is why it is also called as autologous bone marrow transplant.
All right. Dr. Bhargava, the triple drug therapy, high dose chemotherapy, and bone marrow transplant. Now, for a patient who has to undergo all of this, what is the duration of the treatment? And then does he go off drugs? Is he monitored? Does he not need drug for sometimes? For the patient, what is his quality of life like?
Anisha, first of all, every myeloma patient or any relatives who have been suffering from myeloma, you will continue to take the drug till the time you're alive, or we find a way to cure it radically. Okay. So like diabetes or hypertension, you will continue. This is a very common thing in India. सब मैं तो ठीक हो गया, ब्लड प्रेशर ठीक हो गया तो दवाई बंद कर दी, इसलिए अब एक हफ्ते बाद, एक महीने बाद आईसीयू में आके भर्ती हो गया सीधे. So guys, you don't leave, you continue medication. Induction, as Dr. Pawan has said, induction is typically of 84 days to 121 days. Okay, either you can give weekly medication or you can take oral medication. 84 days, once a week you can take it, or once in 2 weeks you can take it, depending on how your doctor wants to treat it. It is as simple as that. And that injection is under the skin, guys, with a 26G needle, which is as fine as an insulin needle. So nothing to worry. So you need not be admitted. You can go out and take it in the community. It's very safe. Okay. One. After that, 84 days to 120 days. After that, what do? You do a transplant or high dose therapy, chemotherapy. Autologous transplant, as you say, it's a scary word because the public has still not graduated. Because मामा की चाची की दादी ने गांव में कहा था कि ट्रांसप्लांट आखिरी ऑप्शन होता है, क्योंकि उन्होंने किसी बॉलीवुड की पिक्चर में 1970 में देखा था कि वो आखिरी ऑप्शन था. No guys, transplant is never a last option. It is a consolidation. It is a part of the treatment. It is not the last mile. It is the second best and the most important treatment which you have. Second most important. Second line treatment which is most important. Second line treatment which is consolidation which is most important. Let's put it this way. Where you stay in the hospital for 10 to 14 days and then you are left alone into the community to do your work. Within 15 to 20 days, you are back onto your work. So any employer who's listening to this, it will be a music to your ears that any myeloma patient can work from home throughout his chemotherapy. During a transplant for 5 days, he can work. So practically, he will not work for you for 10 to 15 days. Only 15 days throughout the treatment for induction and consolidation. Remember that. Following which, you are back into the community and keep on taking the oral medication for which you don't require any holiday or you need not be at home. You can go back to your work. So it means in totality, the oral treatment will continue till the time the disease comes back. Transplant is for 10 to 15 days. Total 15 days for procedure, 15 days rest, 1 month, you're out. And the basic induction is for 84 to 121 days, according to the way we treat. So this is how you treat multiple myeloma in a nutshell. So need not worry. After 3 drugs, there's a revolution which is coming up as we speak. In 10 days, 15 days time, when American Society of Hematology will convene after COVID, they will say 4 drug has become the norm, which is DARA, bortezomib, lenalidomide, and dexamethasone. The 4 drug will become the norm soon, and people will start adopting, because the more we go deep, killing the cells, the larger the amount of time we get. The longer the time we will remain without the disease coming back, what is called as progression-free survival, or what is called as PFS. It's a time to the next treatment. Dear friends, please remember, bigger, we have to make it bigger. 36, 50, 60, 80 months, so that you don't have to come to the doctor. Keep on taking the medicine. Of course, you can call the doctor for a coffee, but you need not be coming to take the chemotherapy back again. That's the whole idea of myeloma treatment in today's world.
All right. Dr. Smear, then is remission, is relapse a given? That I will take this active treatment for some time, then I'll go on oral medication for a really long time, but then I have to go back again. Is a relapse given in myeloma?
Yes, I think good question. We already discussed that myeloma is not curable. So I think most of the patients sometime during the treatment will relapse. But again, as we said, that we have so many medications, so many newer developments, they should not get scared or disheartened at all. Because when we give the induction treatment, we start with our basic drugs. There's already a proteasome inhibitor, or the other drugs like lenalidomide and dexamethasone that we give as standard. But these are just the first drugs in their respective classes of drugs that we give. And the next generation drugs within those classes are reserved for patients who relapse. Sometimes what happens is, if a patient relapses, say after 7, 8, or even 9 years for that matter, we tend to use the first line drugs again and tend to reserve the newer drugs for a later date. So if someone is relapsing late, we would probably start again with the first induction drugs that we had given. In some patients, if they relapse sooner, then we'll go for the newer drugs, which have got even better response rates, and they can have even a prolonged survival at that point. Some patients may ask, can we do a second transplant? So typically we say that if after the first transplant the patients have had a good run without disease for at least 18 months or higher, and if they are still quite young and fit, there is no reason why we can't offer them a second transplant as well. Because as we know, as Dr. Rahul said it very nicely, we want to extend the time before they come back to us. And the best modalities are these: to use the newer drugs, to use judicious use of, I would say, high dose therapy and stem cell rescue, which I think Dr. Pawan mentioned, because a transplant word is scary. So it is a high dose chemotherapy and stem cell rescue, and then use the newer drugs. As Dr. Rahul also said, that 4 drugs could be the norm. We have got newer drugs like antibody treatment, daratumumab, and even CAR T cell therapy for that matter, which is coming in the pipeline soon. There are a lot of options for patients, and even with even after a relapse, the survival and the progression survival can be very good. So in a nutshell, yes, most patients may experience a relapse, but there is nothing to get scared about. The disease can be controlled fairly well with good quality of life.
All right. So relapse isn't something to be very worried about. Dr. Chandrakanth, from the patient's point of view, I'm trying to understand what happens, because some of the medicines mentioned, like dexamethasone, is a steroid, and a steroid taken over a long period of time affects the absorption of calcium, and hence again those osteoporosis conditions come up. But that is already a complication because of myeloma. The bones are getting affected. So for the quality of life of the patient, how is it? Because say you have the good fortune to survive more than 7 years, what is your quality of life?
So exactly, the treatment of myeloma has been evolving. Initially, we had only steroids, and then we had all those toxic chemotherapies. So now I can say that today the myeloma treatment is chemo-free, no chemo at any point of time. If we have all these novel molecules. So of course, yes, dexamethasone is one of the most potent steroid, and the steroid becomes very dangerous only when I am giving it continuously on a daily basis. But when I give on a weekly in a pulsatile fashion, it is not that dangerous. Secondly, coming on to the bone health, which you really picked it up, bone health is very important in myeloma. So we do anti-myeloma therapy with whatever regimens Dr. Rahul and Dr. Samir said. Very important. We have to control myeloma, but what about the already damaged bones? They may fracture any point of time. The moment a patient has a fracture, he in the spine, he may have a permanent paraplegia. He may be on the stretcher, but he may be alive. So then the quality of life is at compromise. So we have something called bone modifying agents or bone remodeling agents. So it can be a monthly injection, what we call as a zoledronic acid. It's a 30 minutes injection. We give once a month for a year, and then we can give once in 3 monthly. Or we also have injections in the skin, just like bortezomib or insulin, like denosumab. So very important, as you picked rightly. We were lost in treating myeloma, and we were passionate about transplant. But these minor things of bone health, calcium, vitamin D, and if there is a pathological fracture, we have to fix the fracture. And if there is a weight bearing area, we have to immobilize these. This is all in the initial part. The moment you're taken care of myeloma, then that's okay, it starts healing. But in the initial 4 months, this pathological fracture, paraplegia are very important. So yes, we have to treat myeloma with the best possible treatment, including autologous transplant and monoclonal antibodies. And we must also take care of supportive measures for bone health, like zoledronic acid and denosumab, calcium, and vitamin D supplementation. And then coming on to what is called steroid toxicities. Diabetes is a problem. Sugars keep going up. We have to test sugars regularly. And the patient's face becomes moon-like, what we call as a moon face or a Cushing's face. So we always have to look into risk-benefit ratio. Here the benefit is too much, and the risk, we have to little accept that bit of risk. And thirdly, there's something called opportunistic infections because of steroids. So we give tablets like cotrimoxazole on a weekly basis to prevent infections as a prophylaxis or as a prevention. You must take these antibiotics. And then these bortezomib can cause viral reactivations of herpes in our body, what we call as herpes zoster, as we have heard. So we give antiviral prophylaxis with bortezomib. And lenalidomide causes some thrombosis and blood clots. We put them on, blood thinners like ecosprin. So we must treat, and we also use preventive measures to take care of the side effects of these drugs. And with these, if we use, as you have been hearing, the quality of life is just excellent. Mm-hmm. And one last thing I would add before I would conclude. So what does transplant offer? So why are we speaking of transplant so much in that to our own marrow? Why should I take my own blood cell and take on? It's a cancerous cell, right? Why should I take from my own blood and I will take my own blood again? It's a cancerous cell. So the whole issue is there is a drug called melphalan. So melphalan is the most active chemotherapeutic drug till known in myeloma. So the problem is, if I give melphalan to a normal individual, it will just wash off all the cells, including myeloma cells, and also it washes off normal cells. Then there's nothing to function actually. So what we do is we take out those treated, in a treated patient, we take out the normal cells, we keep them outside, and then we give melphalan, and then we give the rescued cells, which we have rescued from the myeloma, from melphalan. Those rescued cells is what we give back. This is what is a peripheral blood stem cell harvest, followed by autologous stem cell rescue, high dose chemotherapy followed by stem cell rescue. So this is what we call. So the advantage of a transplant is a time, what we call as twist. It is the time without symptoms and toxicity. As you said, myeloma can cause symptoms and chemotherapy also can cause toxicity. So it is a time without symptoms and toxicity is what that an autologous transplant gives you. It will give you a period where, if I don't do a transplant, the patient should be on some sort of a treatment throughout the lifespan with the toxicity associated with it. So the time without symptoms and toxicity, the twist is what an autologous transplant gives an edge over the other present treatment options.
All right. Now we've understood the benefits of the stem cell treatment. We're coming towards the close of the show, and Dr. Pawan, I'll give you the last word. If you could tell us what patients and their caregivers should take care of, what should they avoid to reduce their discomfort, like try to reduce the risk of falling or opportunistic infections. What should patients and caregivers do to also make the patient more comfortable?
Yeah, first thing is that they need to be in regular consultation, regular touch with their treating doctor and treating hematologist. So they have to take all the precautions. And if they think that anything abnormal is there, so everything they need to report it to their treating physician. And opportunistic infection, yes, the standard precautions for a patients who are undergoing chemotherapy, they have to avoid public contacts, going in public, frequent hand washing, and taking care of personal and oral hygiene. This is very important because during treatment also, and as a disease itself, because myeloma, when the disease is active, especially in the early phase, when the disease is diagnosed and treatment is started, it's a kind of immune paralysis state. Most of the plasma cells are not functioning well because they are all malignant, and they are means normal antibodies are not formed. So it's a kind of immune paralysis state, and they are at risk of infection. So they have to take all these precautions, taking care of personal hygiene, oral hygiene, and any abnormal symptoms, they have to report it to their treating physician. Plus, during the treatment, they can have side effects related to the drugs, like neuropathies. Sometimes they get low platelet count, so they have to do regular monitoring of blood counts during treatment. And if they have these symptoms, especially the neuropathy and all, so these things they need to report it to the doctor. Sometimes diarrhea and other problems can also be there related to bortezomib. So these are the things they need to take care of. And transplant is actually it's a totally different kind of treatment modality. So wherein they have to particularly very all the precautions which the doctors with the transplant physician advise them. So they have to rigorously follow that. And usually they can be back to their normal life in after transplant. So during that period of time, they need to be really very careful, and after that they can resume their normal activities. And so these are the things which I want to mention.
Okay. Now we come to the close of the show, and I'll take very quick last words from all our panelists. Dr. Bhargav, in one line, what would you like to say about multiple myeloma to patients, caregivers, and the audience?
Be aware of your symptoms. We will and we are together to cure you. Just don't worry. Relax. Even if you have a myeloma, you will live 10 years plus. So just don't worry about it.
Dr. Sameer, your last word for everybody watching?
Yeah, sure. So I'll say live your life, take life as it comes. There is good treatment. There is no need to be scared at all. We are all in this together, and you have a lot of support.
Dr. Chandrakanth, you've explained everything very well for all the patients and for the audience. But the one thing I've understood is that one shouldn't fear this. What is the one thing that you would like to tell everybody watching about myeloma, because cancer is fearful?
Correct. So the red flag symptoms: low hemoglobin, kidney problem, and bone pains. Whenever you find this in any of your grandmothers or fathers, always think, you yourself can think, am I dealing with a myeloma? So because we usually miss, and if you present early, before the damage has happened, it is very easy than the moment you're stretcher bound. So you be aware of these three symptoms. That's it. I want to just say. I think rest all, I don't think anybody can carry home. Low hemoglobin, bone pain, and kidney problem. If this is there, any patient, always think of this disease.
All right. Thank you for secondly putting it for everyone. And thank you all for joining us for creating this awareness. This is our endeavor, that people come to know about this and it doesn't hit them as a rude shock in their face because they've heard about it, they know about it, and they're aware about it. Dr. Pawan, your last words on multiple myeloma. What would you like to say to the audience?
So my last word would be that I want to especially mention about the clinical trials. So basically what happens in people are afraid of trials that if I get enrolled in a clinical trial, some experimental therapy or experiment will be done on me. So it's not like that, because sometimes see, myeloma is not a curable disease. We need to, as Dr. Rahul has already mentioned, that it's a kind of lifelong treatment. So patient has to be on some kind of treatment once the disease is diagnosed. So I'm talking about relapse refractory myeloma. Even if the disease relapses multiple times, there are treatment options there. Many of the drugs are not available in our country, like elotuzumab, isatuximab, then CAR T cell therapy, and anti-BCMA therapy recently approved. So at our center at Artemis Hospital, we are going to start a clinical trial next year on anti-BCMA therapy for relapse refractory myeloma and as a maintenance for newly diagnosed myeloma also. So any patient who want to get benefit and take the benefit of this clinical trial, they can come to our center. So this is the thing I want to mention. Thank you.
All right. I would like to thank all of you for taking the time and joining us to discuss this very important issue of multiple myeloma. It's a cancer. Sounds scary, but one that can be managed very well, where the patients also have a good quality of life. Thank you all for joining us and sharing with us your thoughts and wisdom so that there is greater awareness about this disease. And we hope that all of you will see patients in early stages, which are more easy to manage and less uncomfortable for the patients. Thank you all for joining us today.
Thank you.
Thank you so much, Anisha. Thank you.
Bye, Anisha. Bye, Samir. Bye, Chandrakanth.
Take care. Goodbye and see you soon.
Bye-bye.